Thank you, Chairman. Doctor, my eyes have seen the years. I've seen the light. It's a great pleasure to do two things. One is to debate the winner of this year's CCFA Clinical Research Award on the topic. And the second is really to teach you but where to use azathioprine in therapy for Crohn's disease. And I should mention the general topic was IBD. Jean-Fred contacted me several months ago and said, could we focus on Crohn's? And I said, sure. So I relinquished that. So the simple thing is that monotherapy is dead because it was never effective. And I'll go on and show you that data. And data as to how we should use azathioprine in the setting of Crohn's disease. Beginning in 1979, the first large controlled trial, the National Cooperative Crohn's Disease Study, which 90% of the audience, I'm afraid, doesn't know because you're too young to understand the 70s. But it was a multi-center study for which the Crohn's Disease Activity Index was developed to study sulfasalazine, prednisone, and azathioprine for induction and maintenance therapy in Crohn's disease, and azathioprine was neither effective in induction nor in maintenance. And then in the 1980s, Dan Present and Bert Korlitz, in their trial in New York, suggested that 6-MP was effective in induction and maintenance in kind of a combined manner in patients with Crohn's disease. They taught us a lot about the drug back then, that it took about 3 months to have an effect, but less than 6 months to have a maximal efficacy. And through the ensuing decade of the 1980s through 1990, there was conflicting data on both sides of the Atlantic. In a variety of different small studies in both the US and North America and in Europe. In the 2000s, the past decade, in patients with long-standing Crohn's disease, it was demonstrated that the maximal effect of thiopurine, similar to what we learned from Present and Korlitz, tends to plateau after about 8 weeks. But the absolute remission rates in patients treated with these drugs was about 25 to 30%. And it became questionable whether these drugs actually had a role in induction therapy. And that's going to be my principle, that azathioprine, 6-mercaptopurine, are useful in combination therapy to maintain remissions, but is not useful as monotherapy alone. And indeed, the most recent Cochrane meta-analysis, which you don't need to read in full, simply demonstrated that azathioprine and 6-mercaptopurine offer no advantage over placebo for induction of remission or clinical improvement in patients with active Crohn's disease. It's a summary of numerous studies looking at azathioprine as an inductive agent. On the other hand, the meta-analysis previous looking at maintenance azathioprine clearly demonstrated a benefit, and actually a dose-dependent benefit, in that patients receiving higher doses had a better maintenance benefit after therapy was induced primarily by corticosteroids. Now, the one place where azathioprine or 6-MP may have a role as a monotherapy may be in postoperative Crohn's disease. This was a study that I did in conjunction with Dan Present, Bert Korlitz in New York, and with Steph Targan in LA, and with Paul Rootgertz in Leuven, where we took patients and randomized them to mesalamine, placebo, or 6-MP at a 50 milligram dose. It did demonstrate some reduction in the relapse rate with 6-MP. And there have been several other studies that actually were used either alone, but most effectively, I should mention, was that azathioprine was used in combination with metronidazole, which was the most effective of its role in the postoperative, and particularly in preventing severe lesions in this Cochrane analysis. In addition, patients with long-standing Crohn's disease, the analyses have demonstrated no benefit, as I've shown, for induction. effectiveness in maintenance of remission as well as in steroid sparing and in prevention of the postoperative recurrence. Now let's go back and look at some more recent data that were modeled somewhat after the study by Jim Markowitz and his colleagues in kids, which replicated a study that was done 5 years previously in adults by Candy and Wright. In this study, which is a relatively small study of 55 patients with new onset Crohn's disease who were treated concomitantly with a course of steroids, 6-MP lessened the need for prednisone and improved the maintenance of remission. And I think we've been familiar with this slide that demonstrated that patients on the top who were treated with 6-MP had a lower likelihood of relapse after an inductive course of steroids than patients who were treated with steroids and then placebo. Now, there have been 2 very recent studies looking at the earlier introduction of azathioprine in Crohn's disease. The first is the RAPID study that came out of the JETED in France. And these studies are very complicated, and it's a bit hard to go through. This was a 3-year open label. It was not a open label, but randomized trial. It wasn't double-blinded in 24 French centers that looked at nearly 150 patients with newly diagnosed Crohn's disease who had risk factors for bad prognosis. Patients at young age, perianal disease, or patients who required steroids within the first 3 months of diagnosis. And they were randomized to receive early azathioprine immediately or conventional, meaning in patients who were steroid dependent, patients who had chronic or frequent flare-ups, patients who had inadequate response to steroids, or patients with severe perianal disease. So it was open label, but they were treated in one of these arms. The primary endpoint was proportion of trimesters in remission during follow-up. This is an endpoint that no one has used, and we might have some difficulty in comparison, and there were a lot of different secondary endpoints. Basically, to show you the curve, there was no difference with early introduction of azathioprine in this population of patients. But what I should also mention is if you look at their Crohn's disease activity index in their demographics, these were patients who had a CDAI of less than 100 when they were started on therapy. And then there was another trial done and recently reported called the Aztec Trial that was done by a collaborative Spanish group. Now, what they intended to do in their description in their introduction was they wanted to replicate the Markowitz study, which was done in kids, as I mentioned, who had never received corticosteroids before. So it was an early patient population. There were 2 study arms, azathioprine or placebo, and these were newly diagnosed patients with Crohn's disease. The primary endpoint was sustained steroid-free remission through week 76 with a bunch of secondary endpoints, and here's the data of adding in azathioprine early in that group. There was no significant difference. Now, to be honest, if you look at it, although there were no significant differences, they had a very stringent endpoint, and if you extended their endpoint to a CDAI greater than 220, there was a statistical significance, but not a major difference between patients treated very early on with azathioprine monotherapy. So, early top-down therapy with thiopurines was not more effective than conventional management, which is steroid induction followed by azathioprine. And although they cast doubt on the 2000 pediatric study, it didn't replicate it. And these were somewhat unconventional studies with numerous questions regarding about them, and maybe Jean-Fred wants to review them. So there's one other observational study which I think is important that was recently reported in the American Journal of Gastroenterology that looked at the role of thiopurines in reducing the need for surgical resection. Now, this does not mean azathioprine monotherapy, but it means azathioprine typically after induction therapy, usually with corticosteroids. And I do believe that there is an overall utility of azathioprine in the treatment of patients with Crohn's disease, and this is without biologic therapy. So to conclude, the remaining indications for thiopurines are maintenance of steroid-induced remission or steroid sparing in patients with Crohn's disease, not in the newly diagnosed patients where there was, albeit maybe a modest effect. And there is an effect in the prevention of postoperative recurrence, which is quite modest and needs to be compared perhaps to biologics, but as I will mention again, best in combination with metronidazole therapy. And of course, the strongest indication is in combination with biologics, which we beat to a dead horse, and you've seen this slide more than you've seen, I don't know what. But the benefits of combination therapy in patients who are immunosuppressive and biologic naive with azathioprine along with infliximab therapy. So of course, we always need to weigh the benefits and the risks, and we've discussed some of this earlier this morning. As I said, in combination therapy with biologics, azathioprine is the bad player. That's where the major risks are, particularly of skin cancers, the small but present risk of lymphoma, and as the French collaborative group has also shown, there's a minuscule but increased risk of myelodysplasia. So let's go through again the recently published AGA guidelines on the use of thiopurines and other immunomodulators. And their conclusions were against using thiopurine monotherapy to induce remission. Can't be clearer than that. Using anti-TNF in combination with thiopurines over monotherapy with either agent. Recommending thiopurines over no immunomodulator to maintain steroid-induced remissions in patients with Crohn's disease. So to summarize, where's the evidence for thiopurine in patients with Crohn's disease? Maintenance of steroid-induced remissions when used with steroids to induce remission. Maintenance of postoperative remissions in conjunction with metronidazole and in combination with anti-TNF to induce and sustain at least 1-year remissions in patients with early or Crohn's disease not exposed to immunosuppressive therapy. So, mon cher ami, as far as monotherapy, it's not effective. Thank you.
Come forward.